Assalamualaikum. Dear student, I am Dr. Anisa Sadiq, Senior Registrar Gynae. The, this lecture is actually a continuation of the previous lecture, which I have taken on subfertility. So, this lecture is a continuation of the previous lecture. In the previous lecture, we have discussed about the definition of the subfertility, types of subfertility, sexual conception, causes of subfertility. So, the today lecture we will discuss about the history and examination of patient presenting with subfertility and different investigation, male and female investigation, which we are prescribing to patient presenting with subfertility. So, now the learning objective, which I have already told you in the previous lecture, that at the end of the lecture, you people should be able to know or understand the definition, what is subfertility and what are the causes of subfertility. What are the causes of subfertility in male partner and the cause of subfertility in female partner. And you people should be able to describe the concept of ovarian reserve. What is ovarian reserve? I am telling you, I will explain you this term in today's lecture. And you people should be able that in history, what point are asking from a couple presenting with subfertility and in examination for which thing you people will be watching for an examination and what investigation you people will be prescribed to couple presenting with subfertility. And these things you people should be able to understand the provision and regulation of fertility treatment. That what are different options of fertility treatment, you people should be able to explain that what is ART. ART means assisted reproductive technique, what it is its process and what are the procedure. And you people should be able to understand the outcome and success rate of ART, assisted reproductive technique. In today's lecture will be on the history and examination and different investigation which we are prescribing in patient with subfertility and will be an ovarian reserve. Now, this as a brief review of the previous lecture, that what is subfertility, type of subfertility, natural conception, causes of subfertility, female subfertility, mean what are the causes of female subfertility, what are the you people should watch the previous slides in detail, that causes of female subfertility, as I have already told you, that will be ovulatory disorder, tubal factor, and other problem. The causes of subfertility, to understand the cause of fertility is important because the investigation which we will prescribe to patients suffering from subfertility will be, these investigation will be directed towards the causes of subfertility. Okay, different for different causes of subfertility, different investigation will be prescribed. Now, male factor, what are the causes of male subfertility? Now, I think the previous lecture was up to this. Now, the next lecture is on history, subfertility and examination. So, the history will be taking from the female partner, and the history will be also taking from the male partner. A thorough and detailed history must be taken from patient presenting with subfertility, as this is a couple-centered issue. Mean both couple are involved in this process. So at the time of consultation, both male and female partner should be present so that we will ask history from female partner and also from the male partner. In the female partner, in the female partner, which point you will ask is history from the female? The most important is age. As I have already told you that the reproductive capacity decline in female with age. After the age of 35, fertility issue increases in female partner. And follicular reserve also decreases with time in female. So age is very much important in patient. Age is very important in the history of female. Also, the sperm quality and quantity also affected up to the age of 50, but not much is in the female. The second thing is length of time spent trying for pregnancy. Mean that the couple is how much time spent that the couple is not conceiving. As I have already told you in the definition of subfertility, that 1 year is the cutoff point for the couple to label as subfertile. Mean if the patient are living together, they are regularly doing intercourse and they are trying for pregnancy, but still they are not conceiving. So the length of time is very much important. That for how long they are suffering from this issue, from 1 year, from 2 year, from 3 years. So it is important that from how much time they have spent to try for pregnancy. And the second thing is the female, we will ask from the female is any previous pregnancy. This thing is important to look for whether the couple is suffering from primary infertility or secondary infertility. Yes, I have already told you that primary infertility is that the patient has not conceived previously. And the secondary infertility that the patient is having previous abortion, previous babies, previous ectopic pregnancy. So this is important that the patient is suffering from primary infertility or secondary infertility. And second thing is frequency. This thing also I explained to you in the previous cycle that the couple having maximum coital frequency, they are the more chances of conceiving, and the couple which are having less coital frequency, they have less chances of conceiving. Other thing is occupation. Occupation is also important, and in occupation, the female patient in occupation, if the occupation is having stressful environment, stressful environment, uh, the stressful environment, and the patient is having busy schedule, and there are multiple factors which are affecting the female subfertility. The first thing is that the patient is having some occupation, doing some work, and this they have less time for living together and less time for coitus. And the second thing is if they have a stressful job, then the stress also affecting the ovulation. So they are suffering from ovulative disorder. It is the athletes are those who are involved in activities, these type of activities, these um, are also suffering from subfertility. And other thing is general gynecological history. In general gynecological history, we are asking from the menstrual cycle. So the first thing important is menstrual cycle. Whether the cycle is regular, irregular, the patient is having oligomenorrhea, polymenorrhea, menorrhagia. This is important because regular cycle are mostly ovulatory and irregular cycle and oligonucleotide cycle are mostly involuntary. Other thing is parvaginal discharge. The patient is suffering from parvaginal discharge. Parvaginal discharge are any postpartum bleeding, intermittent bleeding, or any abdominal mass, etc. These things are affecting the fertility. Other thing is previous history of pelvic inflammatory disease. If the patient is pelvic inflammatory disease, means PID. If the patient is suffering from pelvic inflammatory disease, there's it affecting the uterus, causing endometritis. The infection is going upward into your tube. It causes tubal damage and tubal blockage. So the history of pelvic inflammatory disease is also important. First thing, it affecting the uterus, it affecting the tube, and the third is if the infection spread to the peritoneal cavity, then because of this, uh, addition will occur, frozen pelvis will occur. So, his previous history of pelvic inflammatory disease is very important. Now, previous medical and surgical history. If the patient is suffering from previously any medical disorder like thyroid disorder, diabetes mellitus, hypertension, any chronic illnesses, the patient are suffering from subfertility and any previous history of surgery, like the surgery which is important from surgical point of view, the thing which is important mostly related to the pelvic surgery. Also, abdominal surgery, but pelvic surgery is more important. If the patient is having any tubal surgery, any surgery for cyst, any surgery for fibroid, then there are no chances of tubal damage or some adhesion. So the patient has difficulty in having conceiving. So these all points should be asked from the female partner while taking history relating to subfertility. Now, what point you will ask from the male partner? Male factor. Which point we will ask in the history from the male partner, what male factor are involved in patient having subfertility. The, the one thing is erectile difficulties, that the patient, the male is having problem in doing coitus. They have erectile dysfunction, mean they are not properly, no proper erection, no proper erection. So they have quite a problem. And second thing is problem with ejaculation. These are maybe premature ejaculation. That ejaculation occur very early, or some semen is ejaculated outside. So these partner are suffering from subfertility. And genetic causes are male factor infertility. Most genetic factor are genetic causes are male fertility are aneuploidy of sex chromosome, structure abnormality of the autosome, like aneuploidy syndrome, and these deletion, microdeletion of the azoospermic factor region of the Y chromosome. So these patients are suffering from subfertility. I think this is a slide of the previous lecture. These were causes of subfertility. Okay, these were causes of subfertility. I think this is a revised from the previous lecture. Now, I told you in detail about the history from male partner. Now, history of female partner is continued. Main in history from the female partner, we will be asking from any previous treatment the patient has taken. Now, it's whether the female has taken the treatment previously from her subfertility or not. Whether if she is taking fertility treatment, which type of drug she has used, and which type of treatment she has done, and which type of investigation she has done. And from the female partner, we will ask from cervical smear history, whether the patient cervical history, whether the patient has previously giving cervical smear for the screening or not. In general health screen for history of thyroid disorder, patient with thyroid disorder are mostly suffering from the menstrual cycle problem. If female partner is having menstrual problem, then most probably they will be suffering from the subfertility. Now, previous slide, I have explained you that from the female partner, which point you people will ask in the history. Now, in the female partner, in examination, what thing you will see for examination in the female partner? The female partner pelvic examination is very important. In pelvic examination, we will look for any fibroid, like nasal masses, or tenderness, and generally the blood pressure, pulse, height, and weight. These are taking look for examination in the female partner. Pelvic examination. In general examination, as I have already told you in history, that thyroid is important. So the palpation of the thyroid is also important in the female partner. Now, history of male partner. Which point two people will be asking from male partner while taking history of subfertility? This is important because it is, I have told you that the follicular reserve early finishes in the female partner, but the quality and quantity of sperm affecting is effective in the male after the age of 50. So age is important. In the length of time spent trying for pregnancy, this point was I have also told you in the history taking of the female partner and the father any previous pregnancy. Mean if this is first marriage of the male partner or second marriage of the male partner. Whether if the this is second marriage of the male partner, whether this male has pregnancy from his first wife or not. And the second thing is history of mumps and measles causing inflammation and infection of the testes, so it causes arthritis. The arthritis occur when there is spermatogenesis is effective. So the patient is having inflammatory of the semen. Now, in history, we will also ask him from testicular trauma, any trauma to the testes, or surgeries on the testes, and occupation of the male partner is also important. That it is generally a concept that the driver are those working in the chemical factories. They are more prone to semen problem because they affecting the spermatogenesis. Similarly, medical and surgical history is also important. Medical history, the patient with diabetes mellitus, they have also or the chronic medical disorder. And if the male is suffering from chronic medical disorder, they are more prone to male subfertility because the semen quality is effective, the quality frequency is effective. Okay, if there is any surgery and the perineum are in the testes, then the fertility of the male is affected. So these points are important in history taking application suffering from subfertility. Now, examination of the male. While taking examination of the male partner, testicular examination is very important. In testicular examination, the testicular volume, consistency, any masses in the scrotum, absence or presence of cross difference, any varicocele, evidence of surgical scar. These things should be looked in male while doing examination for the male partner of subfertility. Testicular examination is important in patient and subfertility. Now, coming towards the investigation. investigation, what investigation we will be describing to a couple seeking advice for subfertility. It is usually preferable to diagnose a cause of subfertility so that an appropriate treatment can be targeted to a specific pathology. Mean the point is that the in history, detailed history will be taken to look for a proper cause of the subfertility. So the investigation should be cause directed, not to investigation. Okay, it is usually preferable to diagnose a cause of subfertility so that an appropriate treatment can be targeted to a specific pathology. Okay. Investigation are sensible in a couple that have not conceived after 1 year of regular unprotected intercourse. I mean, we are starting investigation in a couple after 1 year of unprotected intercourse. If the patient are lived for 1 year and they have not conceived, after 1 year we are starting investigation. Investigation can be justifiably commence earlier if the couple have a history of predisposing factor, mean if the patient has some risk factor. So the investigations can be started early, not after 1 year. Before 1 year, the investigation should be started if the patient are having risk factor like predisposed such as amenorrhea, oligomenorrhea, PID, pelvic inflammatory disease. Women with low ovarian reserve are known male factors of fertility. So in this condition, the investigation of first fertility should be started earlier. Female investigation, what investigation we are doing in the female partner, the most important is blood hormone profile. In a woman with a regular menstrual cycle, in a woman with a regular menstrual cycle that should include, if the woman is having regular monthly menstrual cycle, then we are prescribing to the female early follicular based follicle stimulating hormone, estradiol, and luteinizing hormone. Early follicular first, okay? And anti-Mullerian hormone is providing particularly helpful in the assessment of ovarian reserve and is independent of the menstrual cycle. If we are prescribing to the patient the AMH, anti-Mullerian hormone, this is independent of the cycle. It means you can prescribe it at any time in the cycle, not in early follicular phase, not in luteal phase, anytime. And the other thing is with luteal progesterone assessment to confirm ovulation. In a woman with an irregular cycle, if the patient is having a regular menstrual cycle, this investigation will be prescribed. In a woman with irregular menstrual cycle, the other investigation like thyroid function test, serum prolactin level, serum testosterone level, these will be prescribed in a patient who is having irregular menstrual cycle. And chlamydia testing. Chlamydia testing should be offered prior to any uterine instrumentation. If the assisted reproductive techniques is to be offered, viral screening for human immunodeficiency virus HIV, hepatitis B, C should be offered. These are female investigation. Okay. Now, transvaginal ultrasonography. Transvaginal ultrasonography should be performed where possible. This provides an accurate assessment of pelvic anatomy. This provides an accurate assessment of pelvic anatomy, including uterine size, shape, and presence of any fibroid, ovarian size, position, and morphology. With entered follicle count, an important parameter of ovarian reserve. Entered follicle count is a very important parameter of ovarian reserve. From the entered follicle count, we are assessing that how much ovarian reserve is present in this lady. Methods such as hydrosulfins and endometriotic cyst endometriosis are diagnosing by doing transvaginal ultrasound. Other investigation which we are prescribing for infertility or subfertility workup in the female is tubal patency. We are assessing whether the tube are patent female are young. Now, tubal patency, which investigation we are doing for tubal patency, I will explaining you in the other slide. Now, coming towards the measurement of ovarian reserve. I have told you in the previous lecture that I will be explaining it to you ovarian reserve. What is ovarian reserve? Female reproductive potential is directly proportionate to the remaining number of oocytes in the ovaries. Mean how much oocytes are present in the ovaries. Oocyte, how many oocytes? Ovonia are present in the ovary. From this, we are suggesting, and from this, we are saying that the patient is having how much ovarian reserve. This is called ovarian reserve. Mean the number of oocytes in the ovary is basically ovarian reserve. Ovarian reserve declined after the age of 35 in an average healthy woman at an earlier age due to genetic predisposition, surgery, or following exposure to toxins such as chemotherapy. The ovarian, the oocyte are treated are destroyed in patient earlier. Ovarian reserve can help to protect the response to ovarian stimulation in assisted reproductive technique. ART is basically assisted reproductive technique. If the patient is having good ovarian reserve, they are responding good to ART, assisted reproductive technique. If the patient is having less ovarian reserve, means less number of oocyte, there is poor response to assisted reproductive technique. Entered follicle count, seen at entered follicle count, seen at transvaginal ultrasonography. Transvaginal ultrasonography is a good indicator of ovarian reserve. Less than 4, if there is entered follicle count is less than 4, it predicting low response to the stimulation. And if there is more than 16 entered follicle count, then there is very high response to ovarian stimulation and very high response to assisted reproductive technique. Mean entered follicle count is a good predictor of indicator of ovarian reserve, and from the entered follicle count, we are assessing the success rate of the assisted reproductive technique. AMH. AMH is basically anti-Mullerian hormone. This is produced in the granulosa cell of the ovarian follicle. Mean it is producing in the ovarian follicle and does not change in response to gonadotrophin during the menstrual cycle. Mean the AMH anti-Mullerian hormone has no relation with the timing of the menstrual cycle. As a result, it can be measured and compared from any point in the cycle. In the present, it is the most successful biomarker. Neither AMH nor entered follicle count are perfect indicator, and most clinic utilize both process ovarian reserve. From the entered follicle count and from the anti-Mullerian hormone, we are assessing the ovarian reserve. If the patient is having good ovarian reserve, there is high chances of fertility. If the patient is poor ovarian reserve, then the patient is having poor chances of the fertility. Now, coming towards the tubal assessment. Tubal assessment, two things are we assessing in the tubal. What is the tubal patency, whether it is long or it is patent, and the second thing is function of the tube. Tubal are the patency of the assessing the patency of the tube. Different techniques are taking investigation are present, but there is currently no good test available to assess the function of the tube. So, what do we patency and assessment of the uterine cavity are investigation investigated by hysterosalpingography. This is investigation in which we are doing in patient that the female partner part assessment of the tube. In this hysterosalpingography, we are doing X-ray. In hysterosalpingography, I am telling you a brief procedure of this tubal assessment. Hysterosalpingography. In hysterosalpingography is basically that in the we are passing a catheter, means Foley's catheter to the cervix into the uterine cavity. And to the Foley catheter, we are injected some dye, which are extra detectable, into the uterine cavity. And after giving the dye, we are taking his X-ray of the patient. X-ray. And if the dye is present in the uterine cavity, it passes through the fallopian tubes into the peritoneal cavity. Mean the fallopian tubes are patent, but if we are giving the dye and it is only outlined the uterine cavity, there is uh, dye present in the tube, but that did not spill into the peritoneal cavity, then it means the tubes are blocked. So this is very important investigation in stereosubphysiography, which we are doing assessment of the tubal patency in female partner. The other thing is stereo-contrast sonography using ultrasound. And this is the same. And this thing with stereosyntheography, we are taking X-ray, but in the stereo-contrast sonography, when we are passing the Foley catheter, we are injected some dye and we are injected normal saline, and then we are watching for this normal saline are dying by doing ultrasound. By ultrasound, there will be the dye are normal saline will be present in the form of free fluid in the peritoneal cavity, and by which we are assessing whether the tube are patent or not. And now it is 3 days stereo-contrast sonography, 3 days investigation are present for assessment of the tubal patency. Other thing is a laparoscopy and hysteroscopy is a due diagnostic and therapeutic procedure. In laparoscopy, in laparoscopy, steps of in place of steps of sonography, we are also performing laparoscopy, and laparoscopy is both diagnostic and therapeutic. In diagnostic purposes, we are doing the for diagnosis of different pathology. In laparoscopy, we are watching where there is any ovarians, any region, any other factor. So we are watching for the diagnosis, and if there is some assessment, if there is some adhesion or some cyst, then we at the same time when we are performing the diagnostic procedure, we are also doing therapeutic. The cyst is removed, the adhesion are break, okay, and same it is in hysterosalpingiography and laparoscopy. The dye is passing through the cervix, and the spillage is through to the laparoscope into the peritoneal cavity. And hysteroscopy is also same. The hysteroscopy is also performed through the cervix, and we are watching for different diagnostic purposes and for therapeutic purposes. In hysteroscopy, the uterine cavity is watching for any fibroid, for any adhesion, for any polyp, and at the same time, we are also performing therapeutic procedure. We are using a hysteroscope. If there is some mucosal fibroid, small fibroid, we remove it at the time of hysteroscopy. If there is some adhesion, we break it through hysteroscope. If there is some uterine polyp, we are remove it during these hysteroscopic procedure. So these are investigation for the tubal assessment and other investigation which we are performing on the female partner. Now, this is the picture of the hysterosalpingiography. This white color is basically urogrophin dye, which is passed through the uterine cervix. It is outlining the uterus, and on this thin white, this is the one tube, and this is the dye, which is present in the peritoneal cavity, and on the other side, this is also outlining the fallopian tube, and this is the free fluid spill in the peritoneal cavity. This is a picture of the normal hysterossalpingograph. This is a picture which is also showing the hysterossalpingography, but in this picture, look to this tube. This is a beaded appearance. Beaded appearance means this is a normal tube. Look to this tube, which is a thin line like this, and look to this picture. This is a beaded appearance, and this beaded appearance occurs when the patient is suffering from chronic pelvic inflammatory disease or tuberculosis. The tube damage and beaded, giving a beaded appearance on the hysterossalpingograph. And this is the uterine cavity, which is normal. This is also the uterine cavity, which is looking normal. Currently, there is, as I have already told you, that currently there is yet no effective test to check for tubal function. The tubal patency is regularly checked by doing different investigation, but the tubal function part assessment of the tubal function, whether the tube's motility is normal, the tube is function normally, the cilia are present normally. In the tube, there is currently no effective test to check by the tubal function. The other investigation, which I have already explained, these are by the checking of tubal patency. Now, which investigation we will prescribe while doing investigation for male investigation? In the male investigation for subfertility, the only routine investigation and mild side is semen fluid analysis. We are doing semen fluid analysis in the male partner, whether the different parameters of the sperm semen are normal or not. When we are prescribing semen analysis to the male, then there should be a 2 and 4 days abstinence from ejaculation before providing the semen sample. If the some of the male partner is giving semen for the analysis or testing, then there should be at least 2 to 4 days abstinence from coitus, okay, so that the report is normal. If the initial semen fluid analysis is abnormal, it should be repeated 3 months later to allow adequate time for spermatogenesis. So, if the semen analysis report is abnormal, then it should not be repeated early. At least it should be repeated 3 months later to give adequate time for the spermatogenesis. So, in the female male investigation, is the semen fluid analysis is important. Now, serum FSH, serum AH, and testosterone for men with low sperm count and azoospermia. If the patient is suffering at the male, if there is we prescribe to male semen fluid analysis, if there is abnormality in the semen, then for that abnormality, we are prescribing the male further investigation like follicle stimulating hormone, luteinizing hormone, and testosterone. In detail, these are hormone tests are basically telling us about what are the causes of azoospermia and where the defect is present. Cell defect is present or peripheral cause is present for the azoospermia. And karyotyping and cystic fibrosis screen is also prescribing in the investigation of male partner. If the patient is having cystic fibrosis, then there is also affecting the motility of the sperm. So, cystic fibrosis screen is also important in the male investigation. Now, this you people should be able to remember these parameters. This is the what the WHO parameter for semen fluid analysis. When we are taking the lower limit, the fifth centile, mean not upper point. In the range, we are taking the lower point, mean the fifth centile. In the semen fluid analysis, we are watching for which thing? The semen volume, it should be 1.5 ml, mean it range from 1.4 to 1.7 ml. Sperm concentration, how much sperm will be present? It will be 15 million per ml. In 1 ml, there should be at least 15 million sperm, and the range is 12 to 16 million. Now, the total sperm number, million per ejaculate. The total sperm number should be 39 million per ejaculate. The range is 31 to 36. Progressive motility mean how much sperm are progressively motile. Forward motility, forward not backward, not immotile, sluggish motile, progressive motility, active motile. It should be 32% of the total ejaculate. 32% sperm should be progressively motile. And the range is 31 to 34. Morphology of the normal form mean how much sperm should be in ejaculate, how much sperm will be morphologically normal to fertilize an oocyte. Mean 4% of the sperm should be normal for fertilization. And the range is 3 to 4. And the second is vitality live sperm. How much live sperm should be present? 58%. 58. The range is 55 to 63. And what should be the pH? of the semen, it should be more than 7.2. Okay, these parameter you people should remember this parameter. In any exam point of view, in any MCQs, these things is important. We will be asking these things. Okay, remember this normal value of the semen fluid analysis. I think this is history examination investigation are enough for today lecture, and the next lecture inshallah will be on the management of the subfertility. Thank you. Allah Hafiz.